today I will be covering 3 talks. The first talk will be on borderline cardiac findings, and the second talk will be on the cerebral fourth ventricle, and then the last talk will be on agenesis of the corpus callosum. To start off with the first talk, borderline cardiac findings. I think every day that you go to work and you are scanning the heart, especially in the 3rd trimester, you will find that there's something on the scan that worries you, that the ventricles are different in size, whether the pulmonary artery is enlarged, whether the aorta is dilated, whether you think the heart is in the center of the chest, where you see intracardiac echogenic foci, and you're not sure, is it normal or is it abnormal? So what I want to do today is to walk you through cases of problems that we see in the heart that is a headache for the doctor and a concern for the patient. And what I want to do is to give you some idea as to how to get out of trouble, how to work out what's benign, and how to work out where's the problem that you need to investigate further. And in many circumstances, investigating further means bringing in a pediatric cardiologist to help you out. So I'm going to go through today's talk looking at hyperechogenic foci, because sometimes these can be quite worrying. And then I'll talk about tricuspid valve regurgitation, because this is present in 5% of pregnancies. You want to know from me, when is tricuspid valve regurgitation abnormal? When does it become a benign finding? When does it become abnormal? And the most common situation that you are faced with is when the ventricles are different in size. During the first trimester of pregnancy, the ventricles are pretty much the same size. And when you go back to 10 weeks, they are always the same size. In 20 weeks, when you do the anatomy scan, most babies, the right and left ventricle is equal in size, but sometimes you see discordance. And in the 3rd trimester, I get a knock on the door. Simon, the ventricles are different in size. Is it normal or is it abnormal? This is very common. And the other thing I get is there's a discordance in the great arteries. I get a knock on the door. Simon, the pulmonary artery is big. She's 32 weeks pregnant. Is it normal or is it abnormal? What I want to do is to provide you with some practical clues how to distinguish normal variants from pathology. And then I will talk about pericardial effusion, the definition, and I'll finish up then with cardiomegaly. I don't know if it's possible. Can we turn down the lights in the room? Is that possible? Because it might be easier to see. Okay, so we start off with intracardiac echogenic foci. And I think many of you are aware that when you do a scan and you see intracardiac echogenic foci, that this is a common finding in the 2nd trimester of pregnancy. And if somebody could do the video clips for me, that would be great. So, this is you scanning. This is you scanning, and you see 2 intracardiac echogenic foci. My question to you is are you concerned? Well, let me say firstly, if I see intracardiac echogenic foci, the first question I always ask is has the patient had cell-free DNA? Because if this is the only finding, and the patient has cell-free DNA showing a low risk, I am not concerned regarding chromosome problems. 90% of intracardiac echogenic foci are present in the left cardiac ventricle. But at the same time, I'm sensible. I know that intracardiac echogenic foci may be a normal variant, but I still look for markers of Down syndrome. Now this baby is 23 weeks pregnant, and when you look on the 4 sections, you see that the nuchal fold is increased, the nasal bone is short, there's intracardiac echogenic foci, and when you look at the final segment, you see there's ventricular dilatation, mild ventricular dilatation. So in a situation where I see intracardiac echogenic foci, even if the NIPT is low risk, I look for the other markers for Down syndrome. And if I find one other marker, I will then go ahead and offer the patient amniocentesis. That baby had trisomy 21. If you look at intracardiac echogenic foci, this gives rise to a 6-fold increase of having a baby with Down syndrome. But if there is no ventriculomegaly, no increased nuchal fold, no echogenic valve, no hydronephrosis, no short humerus, no short femur, no aberrance of clavia, and a normal nasal bone, it's a completely benign finding, and I do not worry about it. So in summary, if you see an intracardiac echogenic focus, if the scan is otherwise normal, and she's low risk on cell-free DNA, there's no indication to offer an amniocentesis. But sometimes it can be quite challenging. In this case, you see intracardiac echogenic foci in both the left cardiac ventricle and in the right cardiac ventricle. Now I ask you a question. Does the presence of intracardiac echogenic foci increase the chances of the baby having a cardiac defect? And the answer is yes, it does. So if you look, if you've got intracardiac echogenic foci, 4% of these will have an underlying congenital heart defect. It's more likely if it's in the right cardiac ventricle. So if I see intracardiac echogenic foci, the next step is I look at the anatomy of the heart. Now, if you look at the AV canal, you see that you can see that the valves are not offset; they're linear across the heart. This baby has got intracardiac echogenic foci, and it has an AV canal defect. So you worry first about Down syndrome, and then you worry second about an underlying cardiac defect, because you know that there's an association between intracardiac echogenic foci. And then if you see multiple intracardiac echogenic foci, you then start getting worried, because you're seeing foci here and foci here. You need to consider the possibility of infections, intrauterine growth restriction, hypoxia, and autoantibodies. So if you see diffuse intracardiac echogenic foci, if you see echogenic foci extending to involve the myocardium, you need to start thinking about other causes, such as cytomegalovirus, Coxsackie virus, and you also need to consider the possibility of evolving critical aortic stenosis. So, in this patient here, you can see a bilateral intracardiac echogenic foci in a fetus that has got abnormal rhythm disturbances. And the reason why it has intracardiac echogenic foci is because this patient has got anti-Rho antibodies. So there are intracardiac echogenic foci, there is complete heart block, and the reason is the patient has anti-Rho antibodies. In this case, in the first trimester, do I worry if I see intracardiac echogenic foci in the first trimester? Because if you look at it, somewhere in the order of 2% of pregnancies in the first trimester will have intracardiac echogenic foci or indeed cord cysts. And when you see the same patient back at 20 weeks of gestation, it looks exactly the same to what it looked like at 13. It was a benign, isolated finding. But it's important that you consider cell-free DNA. It's important you look for markers of trisomy 21. It is important that you examine the heart to make sure that there's no signs of an associated abnormality. So I want you to travel with me through 6 cases, and I want you to tell me which cases are normal and which cases are abnormal. This is the first case. Intracardiac echogenic foci in the right cardiac ventricle and a tiny one in the left. Intracardiac echogenic foci in the right cardiac ventricle, is that a rhabdomyoma? Intracardiac echogenic foci in the right cardiac ventricle, is that a prominent moderator band? Intracardiac echogenic foci extending the length of the interventricular septum, and I'll stop there. It can be challenging to distinguish between normal and abnormal. This is benign. This is a moderator band. This is a moderator band. These three on top I am not concerned about, but they are so subtle that I do not make the call at a single examination. I bring them back and I re-examine them to see whether those foci have increased in size. Because I'm concerned about the possibility in these two cases of rhabdomyoma, but they were normal on follow-up. This case is far more sinister. I'm worried about this case because it's not a focus. It's a tubular, narrow collection down the interventricular septum. Intracardiac echogenic foci exist in the chordae tendineae. If you have foci in the endocardium or you have foci in the myocardium, you need to start thinking about different pathologies. In this case, you see multiple intracardiac echogenic foci. At the beginning, it looks like the chordae tendineae, but when you look closely, you see there are 8 different foci. This is a fetus with multiple rhabdomyomas. And in this case here, when you look at the apex of the heart, you see that there's a hyperechogenic focus, but this is not in the chordae tendineae. This is in the myocardium. This is the cardiac rhabdomyoma. And when you see a cardiac rhabdomyoma, the first thing that I do is I look at the cardiac ventricle in long axis, and then I look at the cardiac ventricle in short axis. And if I look at it in short axis, I also see features of a rhabdomyoma, then I go looking at the brain to see if the rhabdomyoma is. And you know, I am not worried about rhabdomyomas from the cardiac point of view, because it is very rare to develop cardiac complications from rhabdomyomas. It is very rare to get obstruction of the left ventricular outflow tract or the right ventricular outflow tract. It is rare to get rhythm disturbances prenatally. For most of these babies with rhabdomyomas, they disappear after birth. It's not the rhabdomyomas I'm worried about. It's the association of the rhabdomyomas with tuberosclerosis that I'm worried about. Because the majority of these babies have tuberosclerosis. And when I see these massive intracardiac echogenic foci arising from the cardiac ventricle, the next thing I need to consider is to testing for the gene mutation TCS2, because 80% will have a gene mutation of TCS2. About 20% of them will have TSC1 gene mutation, and they tend to run in families. But these are troubling diagnoses because the outcome may result in severe intellectual disability, autism, and epilepsy. And it's important to pick these diagnoses prenatally because there is good evidence that if you treat these patients immediately and prophylactically, postnatally, that you may reduce the risk of neonatal seizures. So it becomes important to distinguish between cardiac rhabdomyomas versus intracardiac echogenic foci. I will also say, when you see an intracardiac echogenic focus and you think it's a rhabdomyoma and you think it's single, the chances of it being tuberosclerosis are much lower when compared to the possibility of it being multiple. But when you think it's single, if you take out a high-frequency probe, you will find, if you look closely at the apex of the heart, that there are 6 additional rhabdomyomas in the apex of the heart with the high-frequency probe. So be very, very careful about counseling a patient and saying, there is only one rhabdomyoma, because the chances are that you're wrong, that there are multiple rhabdomyoma, and you need to take a high-frequency probe and have a close look. So in terms of me deciding, is this normal or is this abnormal? The next step that I want to look at is a short axis section. Because on the short axis section, if I see that this is arising from the wall, then I know that that is a rhabdomyoma. That is not a moderator band, that is not an intracardiac echogenic focus. So you see, it can be extremely subtle. It can be a headache for the doctor, it can be a concern for the patient. And you need to follow through these patients and review them later if you are uncertain. You need to consider starting off exome sequencing or gene mutation, looking for TSC1 or TSC2, and you need to review the patients later with pregnancy. You need to monitor these patients regularly for looking for outflow tract obstruction and rhythm disturbances. But this is extremely rare in nature. Now I'm going to ask you a question. Do you think this baby has got an intracardiac echogenic focus? Excuse me for a second. I'm sorry, I had to remove that video clip because the patient's name was on the clip. So if you look at this case, I ask you the question, is that an intracardiac echogenic focus? And are you worried about the possibility of Down syndrome? Are you worried about myocarditis? Are you worried about a cardiac rhabdomyoma? And the answer is, for these intracardiac echogenic foci, when you look at them, they are the eustachian shelf. You do not get intracardiac echogenic foci in the atria, and if you ever do see them in the atria, it's almost certainly a prominent eustachian shelf. And if you take a stick volume analysis, when you see the focus and you rotate around the y-axis, you will see it is a shelf tissue. It's not a focus of calcification. So it's extremely rare to get these in the atria. What about this case? Do you think this is intracardiac echogenic foci? No, I don't think so. I think this is cardiac fibroelastosis. And when you look sometimes at cardiac fibroelastosis, it looks like an intracardiac echogenic foci, intracardiac echogenic foci, intracardiac echogenic foci, and another focus here. But this is not intracardiac echogenic foci. This is fibroelastosis related to critical aortic stenosis. This left ventricle is dilated. This left ventricle is non-contractile. And the apex of the heart is not formed by the left ventricle, it's formed by the right ventricle. And there's a pericardial effusion. This will evolve into a complete hypoplastic left heart in the third trimester of pregnancy. Okay, so my next question to you is you are faced with a situation where you have a baby where there's tricuspid valve regurgitation. And what are you going to do when you see tricuspid valve regurgitation? How do you know whether the tricuspid valve regurgitation is benign or whether it's true and a real problem? The answer to the question is you need to have a systematic approach to looking at the tricuspid valve regurgitation. So if we follow this case, and I show you the clip, the first thing is you have a subjective assessment. So you ask, does the regurgitation occupy more than 20% of the right atrium? Is the length of the jet more than 1/3 of the right atrium? Is the right atrium enlarged? And is the regurgitant jet consistent, persistent, or intermittent? I can look at tricuspid valve regurgitation and ask these 4 questions, and I will get my answer very quickly, whether it is benign or whether it's reflective of a cardiac malformation. That is the subjective approach. The objective approach is to place a pulse Doppler gate over the regurgitant jet and ask 2 questions. 1, does the regurgitant jet just occur at the beginning of systole, or does the regurgitant jet extend all the way across systole? If it is early systolic, like this jet, this will almost certainly be benign, but if it's a pan-systolic jet, it's more likely to be a reflection of a pathological process in the heart. And the second objective criteria is to look at what is the velocity. Is it 100 centimeters a second, or is it up around 3 meters a second? Because if it's around 3 meters a second, I know at pulse Doppler that I'm dealing with a hypertensive right cardiac ventricle. And I need to look for pulmonary atresia with intact ventricular septum. I need to look for Epstein's anomaly, and I need to look for tricuspid valve dysplasia. But most babies that I see with tricuspid valve regurgitation are benign. They are not any of these diagnoses. So if I go into work tomorrow morning and I see a regurgitant jet, I ask myself the question, does it reach the roof? Is there aliasing? Does it occupy the more 25% of the area? And then I will pulse Doppler gauge. This case, you see the jet hits the roof, and this case in the bottom left-hand corner, you will see it is more severe because there's aliasing. And then in the top right-hand corner, you may appreciate that it's not only aliasing, but you can appreciate here that there's a hypoplastic right cardiac ventricle. So these are 4 cases of a fetus presenting with tricuspid valve regurgitation from mild to moderate to severe with a hypoplastic right heart. And you need to have a subjective assessment and an objective assessment to decide whether it's benign. For these ones that are benign, which is 5%, that's nice. For these ones that are benign, which represent 5% of all pregnancies, and more common in the 3rd trimester, your pulse Doppler velocities will be less than 150 centimeters a second in most cases, and there will be no aliasing. So this is the summary: subjective, objective, and these are the problems that you are looking for. You can divide them into different groups. The abnormalities of the right AV valve, and remember, cardiomyopathy or cardiomegaly can stretch the valves and give rise to tricuspid valve regurgitation. In this case here, you may see where coarctation may result in a tricuspid valve regurgitation. Total anomalous pulmonary venous return may result in tricuspid valve regurgitation. And a hyperdynamic circulation of vein of Galen, chorioangioma, twin-twin transfusion, and trap. Essentially anything that causes a hyperdynamic circulation, anything that causes fetal anemia, the first thing you may see is tricuspid valve regurgitation. So remember, if you're doing a scan at 32 weeks or 24 weeks and you see tricuspid valve regurgitation, do not forget to go to the middle cerebral artery and look at the peak systolic velocity and work out whether it's greater than 1.5 miles. Because if it is, you're looking at fetal anemia, and that may be the first presentation. I will say the exact same thing about pericardial effusion. If you find a pericardial effusion in the late 2nd or 3rd trimester, remember in your report to put the peak systolic velocity moms. In the more examples, this is of severe tricuspid valve regurgitation. So here I see it hits the roof of the atrium, and once it hits the roof, it comes back down like a mushroom cloud. And that mushroom cloud appearance is typical of what you see with pulmonary atresia, with intact ventricular septum, or tricuspid valve dysplasia. This is not Epstein's because the jet originates at the level of the valves. If it's Epstein's, it's going to originate from deep inside the right ventricle. And that's how I distinguish between the two. So these are just more examples of tricuspid valve regurgitation across these cases, and using stick technology. If I get the chance, I will show you today that using stick technology can purify the flow. And you can also see it in the 1st trimester. These are all examples in the 1st trimester pregnancy of regurgitation. This is a baby with a dysplastic tricuspid valve. This is a baby with Epstein's anomaly with enlargement of the atria, and the regurgitant jet arises deep inside the right ventricle. And then the last case here, this shows Epstein's anomaly from a very old case from 2011 with severe regurgitant jet and dilatation of the right atrium. But the jet originates inside the ventricle. Okay, let's move next to ventricular discordance. So you go to work tomorrow morning, and when you do the scan, you notice that the ventricles are different in size. So when you start this scan in the top left-hand corner, you appreciate that the left cardiac ventricle looks smaller when compared to the right. And the question that you ask, is the left ventricle small or is the right ventricle enlarged? And you need to have an approach to work out the answer. In the next case, you see, case number 2, you see it is a little bit more obvious that this left cardiac ventricle is smaller when compared to the right. And when you go to this case in the top right-hand corner, now it becomes very obvious that the size of this left ventricle is very different to the size of the right ventricle. And then you go to the bottom left-hand corner in the fetus at 26 weeks of gestation. This is the left cardiac ventricle, which is significantly smaller when compared to the right. And then in the middle of the image, you have here a small left cardiac ventricle. And in the bottom right-hand corner, you see a tiny left cardiac ventricle. So let me ask you a question. When you go to work tomorrow morning, which of these cases is abnormal? And I know everybody in the room is going to say to me, that's abnormal. I think everybody agrees that that's a hypoplastic left heart. But what about that one? Is that normal? So you need to start looking, firstly, the left ventricle is smaller when compared to the right. You want to ask yourself the question, does the baby have coarctation? Because that's by far the most common situation that's going to give rise to a smallness in the left ventricle, and you'll get a diminution in the size of the transverse aortic arch. You next want to look to see if there's evidence of aortic stenosis. So you want to look at the left ventricular outflow tract, and you want to see the aortic valve on 2D. Does it disappear during ventricular systole? And the next thing you want to do is you want to do a color Doppler over the left ventricular outflow tract, and you want to see is there laminar flow or is there turbulent flow. And then you want to look behind the heart and to see if there's a common venous channel. So in the common venous channel is a total anomalous pulmonary venous return, because all the venous return is going to the right side of the heart, so the right ventricle is big and the left will be disproportionately small. In fact, coarctation and anomalous pulmonary venous return with supracardiac drainage may look absolutely identical, because there are 4 vessels on the 3-vessel tracheal view in total anomalous pulmonary venous return with supracardiac venous drainage, and you may have a persistent left SVC in the setting of a coarctation, very common finding. And the last reason why the left ventricle may be smaller when compared to the right is there is a persistent left superior vena cava. So you need to look for 4 vessels on the 3-vessel tracheal view. But for me, when I go to work, I have just given you a lot of different pathologies. But when you go to work and you are faced with this, and this, and this, if you get laminar flow across the mitral valve, it looks blue as you have, or red as it looks red as you get fill up the ventricle. You look to see is there a blue jet. There is no blue jet. You then look at a left ventricular outflow tract and you get laminar flow, and you look at a 3-vessel tracheal view and you get laminar flow in the 2 great arteries. That is normal, and that is normal. So I ultimately rely on what the valves look like and whether there's laminar flow. And if I see turbulence, I then pulse Doppler gate. And then you say to me, Simon, if I pulse Doppler gate the aortic valve, how do I know when it's abnormal? What sort of numbers do you have in your head? Well, my question to you is in your department, you need to have on the wall a chart that shows the velocity across the aorta and the pulmonary artery across gestation. It's a very important chart to have in your department. And if you want me to give you a figure, most of these cases will present in the 2nd trimester, late 2nd trimester, or early 3rd trimester. And a very useful figure is 100 centimeters a second. Because if the pulse Doppler velocities are measuring more than 100 centimeters a second, then you need to take out the chart, and you need to chart where the centile is at any given gestation, to work out whether it is or not. So these are a headache for me. These are a headache for you, and they're a headache for the patient because you're there showing concern. But if you go through the process of seeing normal valves and laminar flow with normal pulse Doppler velocities, it is normal. So you say, Simon, why can't we measure the ventricles? I mean, everything else in obstetric ultrasound you measure to find out whether it is normal or abnormal. And the answer is, in fact, if you look at pediatric cardiology, there are Z scores for the aortic valve, pulmonary valve, ascending aorta, main pulmonary artery, tricuspid valve, mitral. If I were to Z score every day I went to work, I'd have no time to see the next patient. It's not practical. I know there are charts with Z scores for everything in pediatric and fetal cardiology. But we are obstetricians. We're trying to work out, is it normal or is it abnormal? So I do not measure the width of the mitral valve if I'm looking at a screening context. If I see there's coarctation, there's a narrow transversal, if I see that there's features of aortic stenosis, yes, I will Z-score the mitral valve, and I will Z-score the tricuspid, and I may look at the ratio between the Z-score of the mitral and the Z-score of the tricuspid. But for most patients who are simply normal variants, I do not measure the mitral valve. And the second thing you can do is you can measure the width of the ventricle below the level of the valves. And that's the point where you take that measurement. What do I do? That's what I do. I look at a four-chamber view of heart. I look for any turbulence. I look subjectively for the size of the vessel. And if I see normal laminar flow and a normal three-vessel tracheal view, in terms of seeing that the ventricular discordance, I'm not concerned. The other measurement is the measurement of the length of the ventricle. Again, I do not do this in routine clinical practice. So I want to show you some examples of pathology that I just mentioned to you. This is a feature of coarctation. And you look at the transverse aortic arch, you see reversing the flow. So this baby's left ventricle is small because there's coarctation of the aorta. So I actually get an answer in this case. It is not a benign finding. In this case, I can see that this left cardiac ventricle is smaller compared to the right, but there's a common venous channel sitting behind the left atrium. This baby has total anomalous pulmonary venous return, and that explains the discordance. In this baby, there's a dilated coronary sinus. The baby has a persistent left superior vena cava. In this baby, the left ventricle is smaller when compared to the right. And when you look at the left ventricular outflow tract, you see turbulent flow with a dilated aorta. This baby's got aortic stenosis. When you look at this case, the left ventricle is smaller when compared to the right. And when you look at the left ventricular outflow tract, there's a perimembranous ventricular septum defect with posterior malalignment, and the aorta comes straight out of the heart. And this is the typical feature. It loses the curve of the left ventricular outflow tract. It is straight. And the VSD, you have the aorta collapsed, posterior malaligned VSD. These are the typical appearances that you get with the aortic interruption. And in the last case, the left ventricle is small because the baby's got a diaphragmatic hernia. So these are the 3 or 6 anomalies, the common anomalies that are not benign, that are pathological. But you made these diagnoses because you had a systematic approach of looking at the 5 ischioc sections of the heart with 2D color and pulse Doppler assessment. So in this case, if you look at this example here, I want to show you that you have features that the right ventricle is smaller when compared to the left. This is much less common than a big right ventricle, small left ventricle. But if you ever see a ventricle like this, the right ventricle, you ask yourself one question. You ask, is there tricuspid valve regurgitation? Yes or no? Then you ask the question, is there forward flow across the pulmonary valve? Yes or no? Because you want to know if there are pulmonary stenosis or pulmonary atresia with intact ventricular septum. So now I'm going to show you examples of abnormal right ventricles. So this is a baby with severe tricuspid valve dysplasia. The jet arrives at the level of the atrial valve. This is a baby with pulmonary atresia with intact ventricular septum with a small indented right ventricle. This is a baby in the top right-hand corner with Noonan syndrome with a thickened right ventricle. This is a baby with pulmonary atresia with a thickened right ventricle. This is a baby with twin-twin transfusion syndrome. In the middle image, which has pulmonary stenosis. And this is a baby in the third trimester with pulmonary atresia with intact ventricular septum. So these are examples where the right ventricle is smaller than the left. And these are all the different pathologies that you may see. But again, I say for most, you see ventricular discordance, it represents a normal variation. I want to quickly say a few words about coarctation. How do I deal with coarctation when I go to work? Well, the first thing I see is that there are 4 vessels. 1, 2, 3, 4. And this is quite common in coarctation. And when you look at the right SVC, the right SVC is displaced. We reported this finding back in 2019. We reported this. The displacement of the superior vena cava to the right is the first clue that you're looking at a persistent left superior vena cava. And when you see this displacement to the right, typically the left brachiopathic vein is absent. When you look at this baby, you see that this left cardiac ventricle here is smaller when compared to the right ventricle. Now I'm going to ask you a question. If you were doing this scan tomorrow, what are you going to say to the patient? Number 1, you see that that left ventricle is small. You also appreciate that when you look at the 2 vessels, or 2 of you, that the transverse aortic arch is significantly smaller when compared to the pulmonary artery. And is that normal or is that abnormal? Now that's a very good question, because can I tell you something? That it is, when you look at a cardiac abnormality where we make false positive and false negative diagnosis, coarctation is the anomaly where we make the most mistakes. So when I am faced with a patient where there is a narrow transverse aortic arch, I, in a sense, do not make the diagnosis on a single scan. I will take a measurement of the isthmus from here to here, and I will Z-score the isthmus. Now, if I get a Z-score that's less than 0.2, I'm concerned about the possibility of coarctation, especially if I'm seeing that the left cardiac ventricle is smaller than the right. And yes, I will Z-score the mitral valve, the bicuspid valve, and look at the Z-score ratio between the 2. But I will not make a certain diagnosis. What I want to do is, I want to see this patient again. She's 31 weeks of gestation. I will see her in 2 weeks and 2 weeks. And if the Z-score is getting progressively smaller, and that left ventricle is getting progressively smaller, I'm worried now about an evolving hypoplastic left heart. I'm worried about reversal of flow along the transverse aorta in the case that I showed you previously. So what am I saying? I'm saying is that when you suspect coarctation, be very careful that the false positive rate in the 3rd trimester is somewhere between 30% to 80% of published series. It's very high. And when you tell a patient that there's an abnormality in their baby's heart and you're worried about it, they will never forget that. Even if their baby is born pink and well and screaming, they will never forget when you told them that there was a problem with the baby's aortic arch. So you have to be very, very careful. And you need to serially monitor these. And only when you see a trend of Z-score change, you see reversal of flow, you see a diminishing left cardiac ventricle, only then do you start entertaining the possibility that she needs to be delivered in a tertiary referral center, and that you may need to give the baby prostaglandins at birth. But you know what happens for most babies? For most babies, that's not what happens at all. Is that this continues to be smaller than that, and it proportionally grows. This continues to be smaller than that, but it grows proportionately on a normal chart. And when the duct closes, when that closes off, that aorta expands and opens. It's an elastic structure. And you will get normal flow across the transverse aorta. But I can't tell which ones are going to do that versus I can't tell which ones are going to evolve in a hypoplastic left heart. I wanted to cover that with you. You know what? There is no more
difficult abnormality in coarctation. It's the single most challenging. It's a headache for me, and it's a concern for the patient. Look at the number of indices that have been described. There's over 30 indices that have been reported in the published literature saying these may help you distinguish the false positives from the true positives. It is very difficult. And you said to me, which do I think are the best? Let me tell you. I think the isthmus diameter Z-score of less than 0.2. I think the isthmus to duct ratio diameter of less than 0.7. Compare the two, it's always a good thing. And I think the tricuspid valve to mitral valve ratio. And I chart that with progressive surveillance. These are the most useful markers, I think, in screening. Of course, I then go to a sagittal section, and there are two types of coarctation. There's a focal coarctation, and this is a focal coarctation. This is the antiductal shelf. These are the most difficult ones. The tubular shelf is the entire candy cane. It's reduced in size. The one with the ductal shelf, with focal narrowing, is much more challenging. And you need to look at sagittal imaging with color Doppler examination to make these diagnoses. Okay, I think that's enough cases of coarctation. I just might skip them. I want to share with you this case because I've spoken about false positive diagnosis. What I'd like to do is now share with you false negative diagnosis. So this is a patient of 32 weeks of gestation who I saw with a pediatric cardiologist because we were worried that the transverse aortic arch was smaller when compared to the pulmonary arch. But it's pretty subtle, do you agree? It's pretty subtle. And when you look at the left cardiac ventricle, it is smaller when compared to the right. This baby was pink at birth. And the Doppler assessment or clinical assessment of the baby was normal. But at 6 weeks after delivery, this baby collapsed and came into emergency with severe coarctation. So I went back and I looked at my images and said, how did I miss it? Because it didn't look that dramatic. And I went back and looked at the clip, I said, well, maybe the ascending aorta looks a little bit narrow. So when I looked at the three-vessel field view, to me that transverse aortic arch looks good. So most negative diagnoses are similarly well reported in this condition. It's extremely challenging. Pulmonary stenosis is an abnormality that most obstetricians, sonographers, sonologists miss. It's one of the most common congenital heart defects. And why do we keep missing it prenatally? We keep missing it because we are not looking at the pulmonary valve when somebody comes in for a blood scan in the third trimester. If you look at the ICUR guidelines, you will see that as part of the ICUR guidelines that came out in 2024 for a third trimester growth assessment, that you should look at the outflow tracts. Now, if you are going to look at the outflow tracts, then I would say look at the pulmonary valve. Here's the pulmonary valve. And I'll show you this in live scanning. It's important to show the right ventricle in the same plane as the pulmonary valve. This is a very obvious case of pulmonary stenosis because you can see that the pulmonary artery has got post-stenotic dilatation. You can also see that there is turbulent flow distal to the pulmonary valve. You can see that there is severe tricuspid valve regurgitation. And when you look at the pulse Dopplers, it's up around 3 to 4 meters per second, 300 to 400 centimeters per second. It's way off the chart. And I don't think anybody in this room will miss this diagnosis. And most of these do not present at mid-trimester. Most of these will present in the third trimester of pregnancy. But they're not always that straightforward. And then they ask you, would you pick this case up? And what struck me about this was the valve looks abnormal. It's like a skipping rope. If you look at the valve, it does not disappear during the ventricular systole. But that's a very subtle finding. And the second thing is that when I look at the pulmonary valve, I see turbulence across the pulmonary valve. But if I see turbulence, I have to make sure that that's not a Doppler setting problem. So I need to look at my PRF at the top left-hand corner. And my PRF is up at 74. That's okay. 74 for this gestation late at 29 weeks is perfectly normal. But if my PRF is about 25, then the reason you're seeing this turbulent flow is because you've got the wrong PRF setting. First trimester, 25 to 35. Second trimester, 55 to 65. Third trimester, around 75 centimeters. So you have to set your PRF as a priority in any scan you do. Then you change your power, then you change your gain. This is a baby with mild pulmonary stenosis. These generally do very well, but I always worry about Noonan syndrome. I worry about Down syndrome. I worry about chromosomal abnormality. And I also worry about associated brain abnormalities. So this is a baby of 27 weeks with pulmonary valve stenosis. On a tomographic ultrasound slice, the stick volume is the pulmonary valve, and you can see the turbulent flow. And the same baby also has a posterior fossa abnormality. So when you see a Blake's pouch cyst, or when you see inferior variant hyperplasia, just remember you need to look at the pulmonary valve. You can hear the sounds of pulmonary stenosis. Normal flow across a valve is juice, 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 juice. Whereas pulmonary stenosis is juice, juice, juice. You can hear the frequency of a stenotic valve. That's important because you hover the pulse Doppler gauge up, you hear juice, you hear the sound, and you ask the patient to stop breathing. And then you take your pulse Doppler gauge. She's got velocities of 150 centimeters a second. And this is mild pulmonary valve stenosis, and I can hear it. So in summary, when you are faced with the great arteries that are discordant, the first thing I look at is I look at the four-chamber view of heart. I look at the AV valves to see if they move normally. I look for tricuspid valve regurgitation or the aortic stenosis. Mitral valve regurgitation. I look at the right ventricular outflow tract, left ventricular outflow tract to make sure that the valves disappear. I then go to the color Doppler with the correct PRF settings and make sure that there is no turbulence distal to the valve or regurgitation proximal to the valve. And if I see anything that is abnormal in what I've just described, then I will Z-score and I will track it. Aortic stenosis, for most of these, it is much rarer than pulmonary stenosis. You will see probably an aortic stenosis once every 3 or 4 months. So it is an uncommon abnormality. You see post-stenotic dilatation, turbulent flow, and when you look at the velocities, they're up around 400. Here's the difference. Here's the sound. And when you look at the waveform, it's like a lollipop. But mild aortic stenosis can be subtle. This is the aortic valve that does not disappear, and there's dilatation of the aorta. When you look with color, Doppler, you see that the aorta is larger than the pulmonary artery. And when you look at the velocities, it's up around 120 centimeters a second. This is very mild aortic stenosis in a twin pregnancy. Okay, pericardial effusions are common. What do we use as a cutoff? The answer is 2 millimeters. Why am I concerned? Because it's a marker for aneuploidy. But in 2024, I have cell-free DNA, so I don't worry so much about Down syndrome. If I see an isolated pericardial effusion and there are no other markers on the scan and the cell-free DNA is negative, I'm not concerned, particularly when it only measures just over 2 millimeters. But I do make sure there's no associated cardiac abnormality. I check for features of torch infection. I look for extracardiac abnormalities, rhythm disturbances. I check for fluid in the fetal abdomen, looking for hydrops fetalis. I look for calcification of the basal ganglia and the bowel, looking for cytomegalovirus infection. And I look to see if there's any associated anomalies. These are 9 cases of babies with trisomy 21 with pericardial effusion. And the one thing that you will see for every single 9 case with Down syndrome, that the pericardial effusion extends up to the level of the AV valve. So most pericardial effusions are on the right cardiac ventricle, they're less than 2 millimeters. But if it extends up to the AV valve, it's far more likely to be a Down syndrome fetus, and far more likely to be a significant pericardial effusion. So that's a practical point. So in this case here, it extends, again, most commonly around the right cardiac ventricle. It extends up to the level of the right AV valve. And then you need to check to go down to the abdomen and the scalp. And when you come down to the abdomen, there is a tiny, tiny collection of fluid in the fetal abdomen coming across here. And the next thing, when I see a pericardial effusion and I see a tiny amount of ascites, then I need to know what the peak systolic velocity is. I need to run a torch screen, I need to run a parvovirus screen, and I need to know, in terms of doing an amniocentesis, I need to run a chromosomal microarray, and if it's normal, I will run exome sequencing. So if you look at all the different causes of pericardial effusion that are not benign, these are several examples. Top left-hand corner, complete heart block, anti-Ro antibodies, supraventricular tachycardias, cardiac diverticulum, which are very rare, a cardiomyopathy with gross dilatation of the heart with a pericardial effusion, critical aortic stenosis with a pericardial effusion, and tricuspid valve dysplasia. So just remember, there are multiple cardiac abnormalities that can lead to a pericardial effusion, and it's very important to examine closely. Also seen in triploidy, pretty common to see it in lower urinary tract obstruction. Anything that causes obstruction to the both fetal kidneys results in renal hypertension, and fetal renal hypertension causes cardiomyopathies, cardiac dilatation, and pericardial effusion. So remember to look at the heart when you have bilateral renal disease. It's a very common finding. You also see pericardial effusions with growth restriction. Severe growth restriction can be a circumferential pericardial effusion, cytomegalovirus, and then of course, the most important one of all, the very last one, a very obvious pericardial effusion, a headache for the doctor, a concern for the patient, but no cause was found. The baby's heart was normal, torch screen was negative, amniocentesis was negative, and had a normal outcome. Quick question for you. Which is a pericardial effusion and which is pleural? A is pericardial or pleural? In pericardial effusion, the lungs are pushed posteriorly. In pleural effusion, the lungs are pushed medially. That's just a quick question for those of you who are very junior in their training. Because from time to time I see patients referred with this picture saying, please assess bilateral pleural effusions. That is not a bilateral pleural effusion. That's a pericardial effusion, and near the lungs here and here. Okay, the last group is cardiomegaly. So if you look at the issue of guidelines, it makes a recommendation in the third trimester that you need to look at the cardiothoracic ratio, and that should be less than 50%. It's very common to find a situation where the heart is enlarged in the third trimester pregnancy. So what do? Well, the first thing is I take a measurement of the area or circumference. I prefer to use the circumference ratio. And I compare the circumference ratio of the heart to the circumference ratio of the chest. You will find quite frequently when you have real, true cardiomegaly that the heart is not heart-shaped, but is spherical. It's like a ball, it's round in shape. And that makes me worry in terms of the cardiomyopathies. I importantly look at the contractility of the heart, and I look to see if the pericardial fluid extends all the way around the heart. If I look at all the causes for cardiac enlargement, this is Coxsackie myocarditis, cardiac rhabdomyoma, tricuspid valve dysplasia, isomerism with dextrocardia, double out right ventricle, AVSD, and cord hemangioma, cytomegalovirus infection, and congenitally corrected transposition of the great arteries with Epstein's anomaly. You see how common cardiac abnormalities present with an increased pericardial effusion. But never forget viral infections. Don't forget Coxsackie. Don't forget cytomegalovirus. And one of the most common reasons I see enlargement of the heart is renal hypertension related to posterior urethral valve syndrome. And when you see in skeletal dysplasias that the heart looks big, it's probably that the heart's not big, but rather the chest is small. So be careful. The cardiothoracic ratio will be abnormal, not because you have cardiomegaly, because you have a reduced chest circumference. So that's a false positive call in a sense.
Another example, posterior valve syndrome, cardiac rhabdomyomas, a dilated cardiomyopathy, and a supraventricular tachycardia. So all of these cases result in enlargement of the heart, and you need to calculate your cardiothoracic ratio, and then you need to run your lights looking for it. If you are ever faced with a chorioangioma, and the technologies today are beautiful, because in the past, 20 years ago, I was never able to see the flow in the chorioangioma, whereas now, current technology, especially with slow flow, you can see the beautiful branching within the mass. The first question I ask when I see a chorioangioma, I want to know, is there a high output cardiac failure? And to give me an answer whether it's going to be a high output cardiac failure, is I look at the distance that this insertion of the cord is in relation to chorioangioma. Because the further away the cord insertion from the chorioangioma is, the less likely it is to result in a high output cardiac failure. In this case, beside it, another case of chorioangioma, and this is showing you with slow flow technology. That is not a subchorionic hematoma, because in the past that's what I used to consider. But no, I'm certain that this is a fetus with a chorioangioma, and you can see that there's a globular dilated heart. This heart is under strain from high output failure. And quite frequently you would also see that there's tricuspid valve regurgitation. So if you see a round heart, a cardiothoracic ratio greater than 50%, and you see tricuspid valve regurgitation, you know that heart could be potentially in trouble. If you see the cardiothoracic circumference ratio is more than 70%, you then start worrying about pulmonary hypoplasia. So if this heart grows to this size, then there's compression in both the lungs. So at CT ratio greater than 70%, always remember that there's that risk that baby's going to run into respiratory distress then after birth. Another example from long ago, from 2010, 14 years ago, you can see the globular enlargement of the heart, cardiothoracic ratio around about 65%, with a pericardial effusion. In this case, it's a mass inside the fetal pelvis. This is a sacrococcygeal teratoma. And look at the baby's heart, you can see is enlarged, globular, but it's very mild. But I would need to monitor the cardiomegaly in the setting of a hyperdynamic circulation with the intrapelvic sacrococcygeal teratoma. And in this case here, you can see tricuspid valve regurgitation. You can see that the heart is enlarged, cardiothoracic ratio around about 60%. And this is the baby who's got a vein of Galen aneurysm. So you can see here, this is the vein of Galen aneurysm just at this point here, with a dilated straight sinus, dilated inferior and superior sagittal sinuses. So when you see vein of Galen aneurysm, just remember, you need to go ahead and examine in detail and to look for cardiomegaly. And also make sure, remember, to examine the brain. This is the grossly dilated straight sinus, and you can see the periventricular leukomalacia, which is a very worrying finding that you get in these vein Galen aneurysms, because it results in significant intellectual deficit. So I'll finish up by saying rare things very quickly. One sentence for each one of these. Mesocardia. The heart is in the center of the chest. It's a common finding. It's benign for most. But remember, think of transposition of the great arteries. Quite frequently, TGA presents first with mesocardia. Measure, when you're looking at a cardiac assessment, do size, axis, rate, rhythm, and situs is the first thing. A foramen ovale flap, more than 50% across, is described as being a foramen ovale aneurysm. And when you see these, they're described in association with supraventricular tachycardias. Quite frequently, you will see some of these are actually touching the wall of the left atrium. For most of these, they are a benign finding and of no concern. When you're doing a scan and you see reversal of flow along the transverse aortic arch in the third trimester, what do you think? The baby's breathing, yes. The most common explanation for seeing reversal of flow along the transverse aortic arch is a baby that happens to be breathing when you're looking at a 3D esophageal view. This baby does not have an obstructed left heart lesion. It has a completely normal heart with intermittent reversal of flow along the transverse arch.
Sometimes when you're doing a scan, you can see aortic override. Now you're worried. You're worried because you think this baby has got tetralogy fallow. And how do you know? Has it got tetralogy fallow? You need to magnify the image of the left ventricular outflow tract. You need to turn on colour. And you need to see whether there's a wash of colour. There is no wash of colour. This is an oblique left ventricular outflow tract view. And when you look at the pulmonary artery is of normal size. There's no diminution in the cavity. This case is very different. You can see that there's aortic override, and now you can see that there's a wash of colour across a perimembranous defect. This is the baby with a perimembranous VSD. So, in summary, you have subtle lesions that evolve over time, and you have valvular lesions. And if you are ever faced with these benign findings, do a 5-sections issue of analysis. Look at the 4 chambers on 2D and look at the bowel movements. Check with color doctor to see if there's laminar flow. If there is not laminar flow, then Z-score the vessels and Z-score the annulus on both sides. And then track the pregnancy to see whether in fact it's a normal variation or whether it's a true pathology. Thank you very much for your attention. Pathology that we all worry about missing, right? It's actually, if you look at it in the Western world, it's a common cause of litigation. A mother goes in to see the GP, her child is not meeting its milestones, developmental milestones. The GP refers to a pediatrician. The pediatrician arranges for neonatal or a cranial ultrasound, and the cranial ultrasound shows that the baby's got agenesis of the corpus callosum with ventricular dilatation. The mother goes back to her GP and says, why was this not picked up on the scan that I had when I was 20 weeks pregnant? Why was this not picked up when I had a scan when I was 13 weeks pregnant? And why was this abnormality not picked up when I went in to have a growth scan at 34 weeks? These are all very good questions. She's a right to know why we did not pick up agenesis of the corpus callosum. And if you read the ISUR guidelines for 2024 and look at routine growth assessment, you will see that as part of the ISUR guideline that you need to examine the brain. You need to look at the cerebral lateral ventricles, because 3/4 of babies with agenesis of the corpus callosum will have ventricular dilatation. And for those with complete agenesis of the corpus callosum, there will be no CSP to do your growth scan at 32 weeks. So it's very reasonable for the patient to ask, why was it not picked up at the growth scan? Is it reasonable for her to say, why didn't you pick it up at the 20-week scan? I'd probably say, I need to look at the images to see. Particularly in Australia, where patients have got a very large BMI. Sometimes the images are terrible that we're looking at. I accept that in some patients, you are not able to see a CSP. And I think if you look at the agenesis of the corpus callosum, I think all of those who've got complete agenesis, the CSP will be absent. So I think you need to understand that looking at the CSP is a very, very powerful indirect marker for agenesis. So when I go back to look at the scan at 20 weeks, I'm not looking at ventriculomegaly to see if we missed ventriculomegaly. I'm going back to look to see whether a CSP was seen. And if there's a good picture of a transventricular measurement, transcerebellar measurement, and a transthalamic measurement, which are the standard measurements that we take at 20 weeks looking at the brain, and there's no CSP in all those three images, well then the patient has got a medical legal case in her hand. And what about if she says that the scan at 13 weeks, I had a very detailed scan at 13 weeks, you did a transabdominal scan, you did a transvaginal scan, and I remember you looking at the brain, and I remember you dividing the brain into 4 sections and looking at all sections of the brain, and you told me it looked normal. Well, it does look normal in a baby with agenesis of the corpus callosum. And if you look at what has been published, there are some indirect markers that have been published at 13 weeks for agenesis. But at the end of the day, you cannot make a diagnosis of agenesis of the corpus callosum before 13 weeks and 6 days. End of story. It is not a detectable abnormality in the first trimester of pregnancy. Seeing indirect markers only raise suspicion and make you do a scan later in the pregnancy around the mid-trimester to make the diagnosis. Now that's complete agenesis of the corpus callosum you worry about and I worry about. But if you look at all the indirect markers which I am going to walk you through, I think they will save the day for you. Because I think after I go through all these markers and you look at these markers routinely in every mid-trimester scan you do, I think it's very unlikely that you will miss complete agenesis of the corpus callosum. Because they will have some of these markers for sure. Where it becomes challenging is partial agenesis. Because about 50% of babies with partial agenesis of the corpus callosum will have no indirect markers. And if that's the case, should you be examining the brain in a sagittal section routinely to directly image the corpus callosum? This is a very controversial subject. And I think the wisdom at the moment amongst the ISUO guidelines is in a screening context, there is no grounds in a screening context to routinely image the corpus callosum. So what I'm going to do is I'm going to cover, I think I'll just do today complete agenesis. So we'll cover the normal corpus callosum, the biometry, and complete agenesis. And I might just say a few words about differential diagnosis. So when imaging the corpus callosum, the best way to image the corpus callosum is anteriorly, through the anterior fontanelle. And then you find the genome, which has a trilaminar appearance. You rotate it on the genome, and this is a very predictable way. And I'll show you a live scan how to get the corpus callosum. This is much better than finding a profile and wandering until you find the corpus callosum. This is the reproducible way. And if the baby is only posterior, the occiput is anterior, you look for the trilaminar appearance anterior and posterior, and then you rotate the transducer. But the best way to image the corpus callosum is anteriorly, not posterior. So always go through the median, mid-sagittal approach. And when you do a transvaginal assessment, you will always get a better picture. And this is looking at a different patient. You find the genome, and you rotate the transducer 90 degrees, keeping the genome in view. And then you will get the rostrum, genome, body, and the splenium. And remember to keep the vermis and vestigial point in view. You have to have an anterior landmark and a posterior landmark. Your anterior landmark is your genome, your posterior landmark is the vermis and the cerebellum. Because otherwise you're going to have an oblique section, oblique mid-sagittal section. You don't want that. So you must have the vermis in view where possible to take the measurement. And once you have that, you then have the option of looking at the pericallosal artery and then looking at 3D. So the ISUO guidelines, which have been revised and updated, and this is in 2020, said there is no recommendation to image the corpus callosum in a screening context. However, there is an indication to image the corpus callosum in a dedicated fetal neurosonography. When you do a screening examination, part 1, you are just looking at 3 sections, transventricular, transthalamic, transcerebellum. You have a posterior landmark in each of these, and the anterior landmark in each of these is the CSP. But it is worth looking at the CSP in more detail. Looking at the CSP, the genome, the pericallosum sulcus, midline phalanx, the medial wall of the lateral ventricle, which converges with the walls of the cave septum collusive. And to show you on the image here, this is the midline phalanx, which is interrupted by the CSP. This is the genome of the corpus callosum. This is the pericallosum sulcus. This is the medial wall of the lateral ventricle. And the medial wall of the lateral ventricle dies centrally to merge with the walls of the cave septum collusive. Important when you're doing that is to look at the shape of the CSP. And I'll mention this in a little later. When you're doing a 3D volume and you cannot get a sagittal measurement of the baby, then magnify your anterior convex and show the genome. Ask the patient to hold her breath, take an 80-degree angle, select it to max, and acquire the volume. And again, remind me, we'll do this in live scan. But this is a very helpful way if you cannot get a sagittal section in routine imaging. Do a 3D volume acquisition. And we'll talk about A-plane manipulation and multiplanar manipulation in the live scan. Please remind me. And also look at the medial wall of the lateral ventricle. Just make sure you look at that nice curvature and you can see it on both sides. And that gives you reassurance, because the lateral ventricles are very abnormal in ACC. So this is part 2 guidelines. And the part 2 of the ECO guidelines 2021 details what you need to look at if you're doing a dedicated fetal neurosonogram. So something has been picked up in part 1. And in this situation, the guideline encourages the use of multiplanar assessment. And this is a transvaginal acquisition of a 3D volume, and then using VCI static with VRSI, it outlines in far more detail the borders of the corpus callosum. Most importantly, it outlines the details of the rostrum and the splenium, which can sometimes be very challenging, and it also outlines very nicely the tilea choroidea. And if you look at the tilea choroidea, it's usually about midpoint of the corpus callosum. So if you're dealing with a short corpus callosum, your reference point is the tilea choroidea, trying to work out whether there's a corpus callosum pathology. So there should be equal side corpus callosum on either side. Very quickly, a recent publication showed that if you have an isolated agenesis of the corpus callosum, then approximately 1/3 of these will have a genetic abnormality. And in a sense, this is why it becomes so important that we pick up isolated agenesis. Because if there is such a finding, then you need to offer chromosomal microarray. So if I go to next to the biometry, I'll be very quick on this. There are multiple different charts in biometry. And I think there are terrible weaknesses on these charts because they're all so different.
And I think the chart that I recommend is Pietro Sinini's chart. And I recommend it because it's nearly 3,000 fetuses, and 2,300 of these are examined at exactly the time we're doing our morphology scan. So if you're doing a scan at 21 weeks of gestation, the corpus callosum length should be between 21.6 and 24.7 millimeters. And this apartment. This is the 3D volume chart, which you cannot use Sinini's because you're required to do a 3D volume. So you must use the 3D, and that's Pashat's chart for the 3D volume assessment. But you say to me, Simon, hang on, stop. Are you telling me that you measure the corpus callosum? And I'll say that's a very good question. The answer is if the corpus callosum subjectively looks normal, there's absolutely no point in measuring. And that's very clear in the ISWAG part 2 of fetal neurosonogram. It's only if I see a brain abnormality, it's only if I see subjectively the corpus callosum looks abnormal in shape, or if it looks very shortened, then I'll measure. So I do not take a corpus callosum measurement like I take a BPD or a head circumference or a femur length or an abdominal circumference and start worrying if it's 2 standard deviations below. We do not measure it. So the only time where I will measure the corpus callosum is in a situation where I see it looks abnormal. And this, for example, is a patient with 20 weeks of gestation. When I looked at the corpus callosum, it looked very, very short. And somebody at the back of the room is going to ask, Simon, I don't think that's a short corpus callosum. I think that's partial agenesis. And I say that's a very good question. But with partial agenesis, you will not have the 4 components, the rostrum, the genium, the body, and splenium. All 4 components are there. That's not partial agenesis. It's important to understand the short corpus callosum and distinguish it from partial agenesis. Because the short corpus callosum is normally formed, it's just that it's short. And using color Doppler will help. So this is a 12 millimeter length corpus callosum, and the range is 19.6 to 22.5. Very short. In a baby, it's got trisomy 18. Complete agenesis of the corpus callosum. I want to run through the axial sections of the corpus callosum. I just need to take a quick toilet break. If you want to stand up and stretch your legs. I'll be back in a second. I just need a toilet break. Is that okay? I just want to go to the toilet. I'll be back in 2 minutes. And work in here. The first thing is when you sweep from superior, you see multiple lines. So if you look at this baby,
there are multiple lines at 16 weeks of gestation. And you look at this baby here, is at 18 weeks of gestation. You see multiple lines because the falx is thickened, the interhemispheric distance is increased, and this is 21 weeks. You see all these multiple lines. In this case here, at 26 weeks of gestation, it becomes even more striking. Where you see the multiple lines are increased. And there's an increase in interhemispheric distance, and now after 26 weeks of gestation. So before you even measure the lateral ventricles, on a very superior measurement, you may see multiple lines. The graphics are shown in the top right-hand corner, is abnormal. The normal is shown in the top left-hand corner for every one of these sections. This is a normal graphics of a normal brain, and this is the brain showing increased sulcations. So you're still very superior. And when you see multiple increased sulcations in this baby and this baby here, this tends to be a finding that you see after 26 weeks of gestation. It's not seen in the early mid-trimester. The next abnormality you'll see is the lateral ventricle, the CSP. So now we're down to the level of the first issue of assessment, the transventricular measurement. In the transventricular measurement, there is no CSP visible. You see the multiple lines, you come down to the lateral ventricles, and when you reach the lateral ventricles, no CSP is visible. This is the most consistent finding. But you can sometimes think you see a CSP, and it is not a CSP. This looks very like a CSP, just here. But that's not a CSP, because it is too far posterior. The CSP is here. This is an intrahemispheric cyst extending posteriorly that mimics a CSP in a fetus with agenesis of the corpus callosum. Ventriculomegaly. If you look at ventriculomegaly, only about 25% of babies will present ventriculomegaly in the trimester. Most will have normal lateral ventricles. In contrast, 3/4 of babies in the third trimester of pregnancy will present with ventriculomegaly. So it is a much more reliable measurement. But this is very late in the pregnancy. You cannot rely on ventriculomegaly to get you out of trouble, because many babies will have normal lateral ventricles with agenesis. When you look at colpocephaly, you can look at the shape of the lateral ventricles. And if you look at the lateral ventricle, they have what's called a teardrop shape appearance to it. And this becomes more striking in the third trimester of pregnancy. And that's a classic appearance that you will also see on coronal evaluation, that you will see colpocephaly. When you look at the distance between the medial wall of the lateral ventricle, of the midline falx to the medial wall of the lateral ventricle, this is A. And you measure distance from the midline falx to the medial wall of the atria posteriorly, this is B. And in babies with ACC, A is greater than B. And if you look at this case, another example here on the right side, you can see that A is out here, and the distance to the midline, A, is greater than the distance from the midline falx to the medial wall. A is greater than B. In normal babies, it's the reverse. B is greater than A in normal pregnancies. When you look at the parallelism of the medial wall of the lateral ventricle, this baby here has got ACC, and you can see the parallel medial wall of the lateral ventricle in this baby with agenesis. Whereas this baby, which is normal, shows a nice normal curvature of the medial wall of the lateral ventricle. And you can also appreciate the nice normal curvature on the near side. It's an important thing to observe as part of a routine scan. The next is the bundle of Prost. And this is a normal baby with a normal CSP. But when you look at babies with agenesis, what you see is that the bundle of Prost is a band of tissue that becomes much easier to see when you look at 3D with BCI. And this is the bundle of Prost. So in a sense, it's not that the corpus callosum doesn't form. It does form, but it just doesn't cross the midline. And this is a bunched up corpus callosum. And this is why, in a sense, A The distance A is greater than B. I did include no ventriculomegaly because 75% of babies at the mid-trimester will have normal lateral ventricles with agenesis. So this baby has got no CSP, parallelism, multiple lines, but no ventriculomegaly. This is a baby in the 3rd trimester of pregnancy. And you look at this, it's a completely normal lateral ventricle, measures 5 millimeters. But this baby's got a midline cyst, it's got no CSP, this baby has got agenesis of the corpus callosum. So babies present with different combinations and variations of the indirect markers. This baby has got a midline cyst. This baby has got a midline cyst which looks like a CSP, but it's not a CSP. This is a midline cyst, which is a common association in babies with agenesis of the corpus callosum. So be very careful when you look at the CSP. You must see a normal configuration of the triangular appearance of the CSP. That is an interhemispheric cyst. And interhemispheric cysts are a good clue for ACC. Sometimes they can be very striking. This is a midline cyst here, but you can see there are also additional midline cysts. And this is the same baby here on sagittal section. When you look at this image, you can appreciate on sagittal imaging that there is no corpus callosum. And when you look at the same baby on color Doppler examination, you will see there's no corpus callosum. So this here is a sagittal section. This is the cerebellar vermis. These are the midline cysts, and there is no corpus callosum. And you see this radial burst appearance and a very abnormal looking. It was called the absent pericallosal artery, which is a bad term. There is a pericallosal artery, but it's disorganized, it's got chaotic branching, and you will see it in most cases of agenesis. You may also find when you're doing an axial section, you see hyperechogenic foci, which may be tubular or nodular. And when you see these foci go onto a coronal sagittal section, because these are very powerful marker of agenesis of the corpus callosum. When you move to the transthalamic assessment, what you may appreciate is that the 3rd ventricle is increased in size. And you may also appreciate when you look at this that the third ventricle may be elevated. So when you look at this case here, the 3rd ventricle is elevated. On this case, just here. So that's the 3rd ventricle which is elevated. So that's also a very useful marker. So that ends all the indirect markers from the superior to transthalamic to transventricular. And looking at all of these measures becomes an integral part of doing an assessment. And if you look for all these markers of ACC, you will not miss complete agenesis of the corpus callosum. So once you see these indirect markers, the next step is you have to make a diagnosis, right? So now you have to go on to sagittal imaging of the brain. And on sagittal imaging of the brain, it's a difficult diagnosis because you're looking at something that's not there. Much easier to make a diagnosis of something that's there but abnormal in its anatomy. In ACC, there's simply no midline C-shaped structure, and this is a fetus at 23 weeks where no corpus callosum is present. It's extremely important that you show the vermis in view as a posterior landmark, because that tells you that you are truly in the mid-sagittal section. When you look at this case here, there's no corpus callosum and my vermis is in view. You may turn around and say, that to me looks like a corpus callosum, but it's not a corpus callosum. And you look at the pericallosal artery for the color, and you see the chaotic appearance of a pericallosal artery with a radial burst appearance in the fetus with agenesis at 22 weeks and 6 days. So they can be challenging. There's no question. They can be difficult diagnosis when they are absent. And surrounding tissues can mimic, make you think that you are actually looking at ACC. It's much easier in the 3rd trimester to make the diagnosis because you have this radial burst appearance in sagittal section. And in this case here, similarly, a radial burst appearance, but no corpus callosum. If you look at the pericallosal artery, I think the term saying that it's absent is a bad term. I think the pericallosal artery is chaotic and very abnormal, and you can appreciate this on looking with 3D volume data sets. So in summary,
I want to run through this case with you. This is a baby who shows increased endohemispheric distance. You see the radial burst appearance of the sulci. You see an increased thickness of the midline phallus. You see colpocephaly, teardrop shape. When you look at A is bigger than B. When you look at the bundle of Prost, you can appreciate with 3D with BCI that the bundle of Prost is abnormal. When you look at the Sylvian fissure, you look to see if there's evidence of associated migration of brain abnormalities. You need to look at the cingulate gyrus anteriorly, and you need to look at the triad occipital fissure. Because if these are absent or malformed, you need to consider the possibility of a migration of brain disorder. When you come down to the midline, you see that the third ventricle is elevated and dilated. So you see this baby has no cadent septum pellucidum. In fact, this baby has got all the markers of agenesis of the corpus callosum. All you have to do now is to confirm it. And to confirm it, you do it in fetal neurosonogram. You do a coronal, sagittal, parasagittal right, parasagittal left. You need to do 4 more sections before you reach a diagnosis. You appreciate, when you look at coronal, that colpocephaly, the best way of seeing colpocephaly. You're looking for any evidence of polymicrogyria by looking at the parasagittal, and you're looking at the extra-axial space to see whether it's increased. And when you see the vermis is on view, you then do a mid-sagittal acquisition. You ask the patient to hold her breath. You take the volume of 90 degrees, you improve the complete head size. You select the A-plane, you use BCI, you see the palms, the medulla, the vermis, the vestigial point, and then absence of the cadent, absence of the corpus callosum, and absence of the cadent septum pellucidum. The brainstem looks normal, there's no signs of a migration of brain disorder, and then the next step is you look at color Doppler and you see this chaotic appearance on color Doppler, and then you use a 3D volume data set, you see the baby's got agenesis. It's sort of icing on the cake. Do you need to do an MRI? No, not to make the diagnosis, I don't. But I need to do an MRI to see if there's any evidence of migration of brain abnormalities. I need to see if there's any periventricular leukomalacia. I need to see if there's any evidence of basal ganglia calcification, because C and B may cause agenesis of the corpus callosum. So I need to go through a systematic approach on MRI to see if there's any evidence of associated brain abnormalities. I'll say just a few words about partial agenesis. So this is a baby with partial agenesis of the corpus callosum at 21 weeks and 2 days. When you look at the corpus callosum, you can see that the corpus callosum formed here. When you magnify the image, this part of the corpus callosum is missing. You have the posterior part of the corpus callosum which is present, and when you're looking at it, you're having difficulty seeing the splenium posteriorly. It's difficult to see the splenium. So if you look just here, you don't see the continuation around the corner. And the pericallosal artery is not that helpful to you because it looks pretty normal. So you go to an endovaginal assessment, and when you look at the endovaginal, this is the vermis, and you can see that this whole anterior portion is missing, and you can see that the posterior portion is also missing. This baby has an absent rostrum and an absent genu, but when you look at the pericallosal artery, it looks completely normal. When you do a volume acquisition with 3D, you use BCI, and when you look at BCI, you see exactly what you would appreciate from 2D. So you come across, this is the corpus callosum that is present, this component is missing anteriorly, and the turning of the corner, this is absent, and this is absent. This is the power of 3D with BCI. You have outlined very clearly the borders. You may argue that maybe it's present here, but very, very thin. But at the end of the day, I would call this a segmental agenesis of the corpus callosum, because this is what the corpus callosum should look like. The problem with these partial agenesis, and look at this case here, similar case. If you look anteriorly, you can follow this segment of the corpus callosum, but the posterior segment of the corpus callosum should continue on like so, is missing. So in any situation when you're finding these, is look for the radial burst appearance in the part that's missing, because you may see that you have a normal cingulate gyrus anteriorly, normal corpus callosum, and then the part that's missing
you will see radial burst appears. And that may be the first clue for you when you image a sagittal section. This is probably one of the largest series of partial agenesis, and which are reported that 53% of these have no indirect markers. But what you can see in these is that the CSP is abnormal. So there's no parallelism, there's no colpocephaly, there's no A is greater than, look at B is greater than A. There's no interhemispheric cyst, there's no ventriculomegaly, but you have a very wide CSP. And it's important to look at that and then to consider dividing the length of the CSP by the width of the CSP. And if this is less than 1.5, you need to consider the possibility. I think the figure will be higher than 50%, and I wait for new data to show this. Finally, when you're faced with a situation when the corpus callosum does not look like a complete agenesis, it does not look like a partial agenesis. In fact, I can see all 4 segments of the corpus callosum in this figure. The 4 segments are all present. But it looks abnormal. I've got streaky, linear echogenicities. It looks much thinner posteriorly when compared to anterior. Another example. It looks like a normal genu. But when I rotate on the genu, I'm only seeing a very small part. I should see a normal corpus callosum. But all I can see is this tiny part here. This looks very thin. This looks thicker. It's a dysplastic looking corpus callosum. So this is corpus callosum dysplasia, or dysplastic corpus callosum. And then sometimes you will do a scan, normal lateral ventricles, normal third ventricle, no interhemispheric cyst, no markers, and you cannot see a CSP. Singular gyrus is present and normal, right occipital gyrus is present, but you cannot see a CSP. The best thing to do in these situations is to go on to a vaginal assessment. And when you look vaginally, you will see, one, that the anterior complex is normal. This is why the anterior complex is so important. The singular gyrus, the pericallosal sulcus, the interruption using the interhemispheric fissure. And when you look here at the genial, the corpus callosum, when you look at the medial wall of the lateral ventricle, it joins the midline, and you do a sagittal assessment, you see a completely normal corpus callosum. In fact, when you look closely, there actually is a CSP present, but it is absolutely tiny. So this is actually a baby that does not have an absent CSP. It just has very little fluid. So there's absence of fluid in the cadence septum pellucidum, and this is a completely benign variant, which you may see before 17 weeks and after 34 weeks. I don't think anybody will miss this diagnosis. It's also a case of an absent CSP in a baby that has a completely normal corpus callosum. So what you're worried about is, could the baby have septo-optic dysplasia? These are extremely challenging diagnoses because what you're relying on is looking for the optic bulbs. And seeing the optic bulbs is only the posterior part of the chiasma. To see the actual full branching of the chiasma, including all components of the chiasma, you need to get the orbit in view, rotate your transducer to see the full chiasma. But even then, it is very challenging on prenatal ultrasound, and it is also challenging on MRI. So in summary, what does this talk, how does this talk make any difference to what you do tomorrow morning? Well, I think first of all, you've got to decide what sort of doctor are you. Are you a screening doctor? Are you a doctor who's expected to pick the needle out of the haystack? Because if you are, you will do a transventricular, transthalamic, and transcerebellar measurement. And you will pick up, using all those indirect markers, you will pick up 100%, unless it's terrible imaging with the patient with large BMI. But assuming adequate visualization, you will pick up all cases, or almost all cases. In medicine, I never say all cases. I never say 100%, but you pick up the vast, vast majority. With partial agenesis, I think if you look at the medial wall of the lateral ventricle, and if you look at the CSP index and look for widening of the CSP, I think you will pick up more than 50% of partial agenesis. If you are a diagnostic doctor, where you say, well, listen, I want to pick up the other cases of partial agenesis, which may not have indirect markers, then you need to sagittally image. And if you do decide to sagittally image, I suggest you look for the trilaminar appearance of Meager and come in through the anterior fontanelle. Rotate your transducer. It's a very predictable and quick way of getting the corpus callosum. And this will help you pick up not just the partial agenesis, but also help you pick up the short corpus callosum, the thick corpus callosum, and the dysplastic corpus callosum. There is no consensus across the world as to whether you should routinely image the corpus callosum. And if you ask me the question, Simon, what do you do in your practice? Do you routinely take a sagittal measurement? And the answer to that question is yes. I have 25 sonographers in my department, and we routinely image the corpus callosum. But we do not take a measurement of the corpus callosum. We do not bring the patient back if we are unable to see the corpus callosum. If we are unable to see the cerebellum, if we are unable to see the fourth chamber view of heart or aquatract, if we are unable to see the cord insertion, if we are unable to see the spine, we bring the patient back. But if we're not able to see the corpus callosum, we do not bring the patient back. So it's like a halfway house. It's the next step towards moving to say, no, bring the patient back and visualize the corpus callosum. What I would say to you is, that's what we're doing. And what I want you to listen to, in a sense, is what is Isiwak saying? Isiwak is saying in the screening context, you do not need to visualize the corpus callosum. In a diagnostic context of a fetal neurosonogram, where you are performing a transabdominal and transvaginal examination, looking at axial, sagittal, right parasagittal, and left parasagittal, then yes. I might stop there. Thanks very much for your attention.
I'm not sure.
I'm sorry, I didn't hear about your mention about the thickness of corpus callosum. So what do you think about that?
It's a very good question. So I didn't say anything about the thickness. In fact, I skipped through a slide and showed a thick corpus callosum. And if you look at the data today in 2024, there's very little data on the postnatal outcome for babies with a short corpus callosum, so all the four segments, or a thick corpus callosum. And in the absence of knowing what the outcomes are in babies who have thick corpus callosum, short corpus callosum, the current wisdom is that you can't counsel patients about a thickness when you don't know what the long-term, short-term and long-term outcome is. The first thing to say is it's very rare to find a baby who's otherwise completely structurally normal. The only thing you see is the thick corpus callosum. Yes, I do see them. But I cannot sit down with that woman and tell her, by the way, your baby's got a thick corpus callosum. Then she says, what does it mean for your baby? I don't know. I can't do that. So what I do recognize is that if the corpus callosum is thicker, then I do a dedicated fetal neurosonogram. And if the dedicated fetal neurosonogram is completely normal, then I will document it in my notes, but I will not say it to the patient. Because if you say it to the patient, that mother is going to worry about that child for the rest of its life. If it goes to school, and in second year in school doesn't do well in an exam, she's going to say, that baby told me, my doctor told me there's something wrong with my baby, right? You have to be very, very careful that when counseling patients, and now the ultrasound is getting better and better, we are seeing things that we never saw before. And that's why, if you look at the issue of guideline, it turned around and said, do not measure corpus callosum. It said because there's no evidence that the correlation of the corpus callosum size or thickness measures an outcome. And the wording in the guideline is it's not synonymous with an anatomical abnormality in the corpus callosum. That's the exact wording in the guideline. And I think that's very wise. I think if we have more data. There is a course on tomorrow night in Isiwak, the fetal neuro sonography course of which I'm chairing. It starts at 2 o'clock tomorrow afternoon, and there's a talk from Karina Haratz from Israel on the thick, the short, and the thin corpus callosum. So if you want to hear more, look forward to seeing you online tomorrow. Anybody else? The other thing is during the live scan, if you want me to show you something, maybe just send a note, write a little note, and send it into the room, and we will look at it. Okay?
Chúng là cái thành sẽ làm ở dưới học